I present a case in this case we use the ICE to monitorize and to guide the implant. This is the history of a 79-year-old man with permanent atrial fibrillation and arterial hypertension, history of hemorrhagic stroke on oral anticoagulant, and history of gastrointestinal bleeding without oral anticoagulant. The gastroenterologic specialist gave antithrombotic medication with enoxaparin and good ejection fraction without valvular disease. And this is the typical history of a patient with a high risk of cardioembolism. In this case, we give usually the anticoagulant treatment, but in this case, the problem is the high bleeding risk that contraindicated the use of the anticoagulant. Usually, we underlying the importance of the pre-procedural evaluation, we suggest to use all sources of imaging to get all information to make a safe and effective procedure. The TEE we heard before is a basic step to understand the anatomy, to rule out the presence of thrombus inside, and to have good information about the dimension of the appendage. In this case, the ostium is 24. Usually, we use to measure the landing zone 1 centimeter distally to the ostium of the appendage, in this case 22. We use routine the CT scan to get more information about the anatomy of the appendage. And this is a volume rendering reconstruction 3D of the appendage. We see a good anatomy of the appendage with the 2 lobes and good neck of the appendage. This is another type of 3D reconstruction using a parametric scale of color that allow to separate different structure in order to visualize better the anatomy of the appendage. And usually we repeat the measurement of the landing zone and of the ostium using multiplanar reconstruction 3D. Is a technique that allows to have the view of the same point from 3 orthogonal views, and the longitudinal, the transversal, and frontal view. And this is the first point that I want to discuss with you. What is the concept of the diameter? We have the maximum diameter is 26, and the minimum diameter is 22. What is the right diameter? Probably we have to move from the concept of diameter to the concept of the area or the perimeter. In this case, the medium diameter is 25.5. The first question, can you switch to the... Okay, the first question is if, in your opinion, on the basis of the anatomy of and the dimension of the pre-screening patient evaluation, is a patient suitable for the LAA exclusion? Yes or not? The question is if this anatomy is suitable to LAA occlusion. Yes. The second question. You have another question? Okay. Would you consider the ICE as a good modality to guide the LAA occlusion procedure? Yes, no, don't know. The problem is if we think that the ICE can replace or could be a good alternative to the TEE in the guidance of the LAA occlusion procedure. Please vote. No, 49%. Yes, 33%. Okay. In the next slide, I will try to convince you that the ICE is a good option. Why the ICE? The ICE, because the ICE doesn't require general anesthesia, it's less discomfort for the patient, and because the ICE allows for continuous imaging without interfering with the fluoroscopy. In this slide, I try to compare the advantages and the disadvantages of the ICE versus the TEE. Basically, if in one hand you have the adjunctive cost of the probe, in the other hand we have the reduction of the time of the use of the cath lab, and that is saved money, and to reduce the cost of the anesthesiology team, and reduce the cost of the dedicated operator to the TEE. In the next few slides, I will summarize some basic concept of the use of the ICE. The different and the main difference between the TEE is the position of the probe. The TEE is in the esophagus, and the appendage from this point of view. The ICE usually is in the right atrium, advanced across through the left femoral vein, and see the appendage from the left atrium. Usually we start from this position. We use the MR imaging to clarify the position of the probe. This is the position of the probe. This is the cone of the view of the ICE, and this is the typical home view. We start usually from this projection, right atrium, atrioventricular valve, and right ventricle. If we turn gently clockwise, we are in this position. We have in front of you the aortic valve, the pulmonary valve, the right ventricle, and if we turn clockwise more gently, we are in this position. We are in front of the fossa ovalis, and we have the appendage here. This is the typical view of the fossa ovalis. Usually the imaging of the fossa ovalis are very nice because the probe is close to the fossa ovalis and just in front of the fossa ovalis. And this is a good projection to perform a safe and effective TRANS-SEPTAL puncture. Question number 3. Where would you position the ICE catheter for the LAA procedure? The problem is where we need of the dedicated projection to see the appendage during the procedure and to monitorize the procedure for a stable position. We suggest right upper pulmonary vein, coronary sinus, left atrium, I don't know. Please vote. Okay, perfect. Basically, we use, can we switch on the presentation, please? Basically, we use two projections. The first and more common projection in the upper part of the right atrium. This is the position of the probe. And the second routine projection is to advance the probe inside the coronary sinus. There are some adjunctive projections from the superior pulmonary vein and from the pulmonary artery, but for the routine use, we suggest these two projections. This is the typical projection for from the right atrium, and this is the view of the appendage from the right atrium, just in front of the fossa ovalis. You see the fossa ovalis and the right atrium and the appendage. And this is similar to the right cranial angio projection. In this slide, you can see the detail of this projection, the fossa ovalis, left atrium, the appendage, and the circumflex artery. To advance the catheter in the coronary sinus sometimes is not safe, is not easy, and we suggest this alternative projection is a para-coronary sinus projection. You put the probe just in front of the coronary sinus and you view the appendage from the down, okay? Just in 3 easy steps you can get this position. This is the typical position of the appendage from when you are in front of the coronary sinus. Go back to our patient. The procedure. This is the manipulation of the catheter. We turn clockwise gently, and then we move posterior the knob in order to get this curve of the probe, and you are in front of the appendage that is here. And this is the view of the appendage of our patient. We have a good detail of the pectinate muscle. We see the ostium here and the body of the appendage. We repeat the measure with the ICE. The ostium is 24 and the landing zone is 22, similar to the TEE measurement. And this is the detail of the septal puncture. You see the needle. This is the position of the radiological position of the needle and the probe, and the tenting. And in the next slide, we compare the position, the view from the ICE and from the TE that are really similar in view for the TRANS-SEPTAL catheterization puncture. Okay. Then we select the left atrial appendage with the pigtail and the sheath. We perform one angio in 40 cranial right, 20. The second view from the caudal 40, 20 right projection in order to have a more or less orthogonal projection. And repeat the measurement. The landing zone is 24 in the cranial and 25 in the caudal. In this slide, I summarize all measurements made. The measurements ranged from 22, around 22 with the echo technique, TE, TE3D, and ICE, and around 25 with the angio and with the CTR. The question is, what is the right device for this patient? The measurements ranged in this area. The question, which ACP device would you choose? 26, 28, or 30? On the basis of the evaluation of the measurement that ranged from 22 with the ICE minimum and 25 with the CT scan maximum measurement. This difference of measurement is frequent because probably the different technique measurement are, usually we get a different with the measurement. We have the result, 28. Okay, can we switch to the presentation? Okay. This is we use a 28 as first choice. This is the catheter with we see a good alignment of the catheter inside the appendage. We open the device. You see that the compression is not really good, but mainly with the TEE, we have good information about the device and the tissues around. The compression really is not so good. And we perform a tag test with migration of the device. We performed a second attempt with the same device, 28. We changed just a little bit the position of the catheter and the position of the device and the echo view during the opening of the device. But when we, can we switch to the question? Would you like to the tag test, yes or not? Do we need to verify the stability of the device or not? Yes. Okay. We perform a gently, can you switch to the presentation? Okay. A gently tag test. Usually we perform to perform a mild traction for several seconds. And this is the result. At this point, we have the question number 6. What would you do now? Another attempt, or we change device? Please vote. Because on the basis of the measurement, it's reasonable to use the 28. Okay, happy with the result? Change device. Okay, we decide to move to the ACP 30. This is the position of the catheter that is more or less the same. We open the device. We monitorize the position of the lobe in the landing zone with the ICE. We open the device. We are seeing the ANGIO and the ICE imaging. We see that there is we have a good compression of the lobe inside the appendage with a good opening of the disc. And we perform a tag test. We keep the position in traction for minimum 1 minute. And the position of the device is good. We see on the ICE the position of the lobe, the position of the disc, and we check the stability of the device on the basis of the adjacent structures. And we decide to release the device. These are the echo ICE evaluation after the placement of the device that show a correct placement of the device, view from the atrium and from the coronary sinus. And we perform the final angio to verify, to check that the appendage is completely exclusion to have a confirm. And the last question, number 7 question, is the first question. I was able to convince you that the ICE is a good opportunity for the LAA occlusion, yes, not, or don't know. Please vote. Okay, with the result? No, I was not convinced, probably. Okay. I conclude, my point of view is that if we have experience with the ICE, the ICE is a good alternative to the TEE. Also, if I think that TEE is mandatory in the pre-procedure evaluation, and especially the ICE, in my opinion, in a situation in which we have challenging cases like esophageal disease or other impossibly to advance the TEE probe. Thank you very much.